Right. I would like to welcome everybody to our webinar and hand over immediately to Alta. Before I do, please remember that question will be addressed by Alta, and if you cannot access the question and answer, you can always email me or WhatsApp me. Thank you. Over to you, Alta.
Good evening. It's my privilege to welcome and introduce Karen Denton, our keynote speaker and presenter of tonight's webinar. Karen has studied all aspects of nursing, has a degree in psychology, and a 30-year plus career in diabetes education. She's lectured internationally. She studied in the Middle East and chaired various diabetes education organizations that include the Pan-Africa Diabetes Educators and Diabetes South Africa. After her return to South Africa, she decided to pursue her passion to give back to the world and joined the Retina SA team, where she is now head of Advocacy and Education. Thank you. She's now one of my colleagues, I'm very happy to say, and we're looking forward to a great event as usual. Thank you, Karen. The floor is yours.
Thank you. As you're aware, I am delighted to be a member of the Retina South Africa team and to have the honor and opportunity to chat to you all today. So the title of this evening's talk is Why Should We Take Diabetes Seriously? And I hope that I answer that for you during the course of the evening. Just to remind you that, as Claudette and Alta have said, we represent Retina South Africa, and we're not a very big team, but we are pretty effective. And I also work very closely, and we collaborate very closely with the Low Vision Centre of Learning. I do have a disclaimer. The program is made possible thanks to an unconditional grant from Bayer South Africa.
Before you start, if anybody has questions, please, we will take them at the end, but you can pose questions on the Q&A or on the chat or by emailing me, claudette@retinasa.org.za. Thank you, Karen.
Thank you. So I'm going to start right at the beginning, because even to this day, I get asked, what is the difference between type 1 and type 2 diabetes? Well, let's have a look. Type 1 diabetes is the one that is insulin dependent. It is also called immune-mediated diabetes. And type 2 is non-insulin dependent, but it could be insulin requiring. So people with type 1 diabetes, if they don't get those injections of insulin, risk death. People with type 2 have the insulin to help them to control their diabetes a little bit better, but the risk of them dying is very, very low indeed if they don't have it. But remember that each and every person is an individual, and I have heard it said time and time again that there are actually probably as many types of diabetes as there are people with diabetes. The next question that I'm always asked is, which is the more lethal, which is the more dangerous? And funnily enough, a lot of people believe it's the type 1, the one that has to have insulin. And that is not the true answer, because the one that is dangerous is the one that isn't looked after. That is the bottom line. If you have type 1 or type 2, if you look after that, the outcomes are pretty positive. If you're unable to care for yourself, the outcomes are not that great, and the risk of complications increase. If we look at type 1, we know that they're usually at a younger age, although not long ago, I came across a guy who was in his 80s, diagnosed for the first time with type 1. So it can occur at any age whatsoever. The onset is very sudden and is usually measured in hours or days, maybe a couple of weeks, but seldom much more than that. The symptoms are usually very pronounced. They're severe. The person gets very, very thirsty. The person urinates a lot. And in fact, if you have a child who's been dry for quite a number of years, and suddenly age 3, 4, 5 years old or 6, they suddenly start wetting the bed. This is one of the things that we need to look at. They become extremely hungry, and the more they eat, the more weight they seem to lose. And the weight just fades away as time goes. Obviously, because the insulin is not there to get the glucose into the cell to provide energy. They are tired, they're weak, they're lethargic, they just don't want to do things. And as I said, these are very severe, pronounced in type 1 diabetes. If we look at a person with type 2 diabetes, however, it can occur at any age, and we're facing younger and younger people. In fact, when I worked in the Middle East, we had a couple of primary school children with classical type 2 diabetes. The onset is a little bit more gradual, and the symptoms are a little bit subtle. The person gets a little bit more thirsty, drinks a little bit more today, a little bit more the next day. They urinate more, and especially if it's an older person, they think, oh, well, it's my bladder getting a little bit weak and old and aging. Everything is always blamed on age. They also have this insatiable hunger, but they gain weight. And we're going to look at where this weight is so that you can look at yourself and your family and your friends and the people in the supermarket queue and determine who is at risk. So they also, unfortunately, have recurrent infections. The epidemiology, we know it is the commonest cause of new blindness today. In developed countries, we know that AMD is the leading cause. In developing countries, diabetic retinopathy. Now, in our country, we have a very mixed population, and we find that we actually have both, a double whammy. So if you have diabetes, you have a 20 times higher risk worldwide of going blind. So this is serious indeed. And in fact, this is one of the early things that a person can do. If you go to your ophthalmologist regularly, they can look at your retina and they can check your retina and pick up changes in the retina years before you know that you have diabetes, years before you realize that you are developing eye problems. The macula is in the middle of the retina, and this is actually a very healthy looking retina with lovely blood vessels, a healthy background. It really looks really nice. But in diabetes, we start getting all these little hemorrhage spots, these little swelling of vessels, the aneurysms. We get abnormal growth of vessels all over the place. And those vessels are terrible because they rupture, they bleed, they're horrible, and they cause major damage. We will talk about them again.
Another problem that occurs frequently with diabetes
is the effect on the lens in the eye. Now, people with diabetes get what we call a diabetic cataract. And we know that about 60% of people with diabetes after about 15, 20 years start showing signs of a diabetic cataract. It is not the senile cataract. It's not the same one that you get from aging. What happens here is glucose flows into the lens. It can't flow out again. And what the body tries to do, it converts that glucose into what it thinks is a more manageable molecule called sorbitol. But sorbitol is a large molecule that you can't see through, and it starts to collect and agglomerate in the eye. And a good optometrist, or a good ophthalmologist will pick up this typical snowflake look. It's called a snowflake cataract, and it is typical of diabetes. There are lots of other things that can go wrong with diabetes. Diabetes predisposes you to foot problems, foot infections, foot damage. It predisposes also to amputations. And once again, it's one of the leading causes equal to trauma worldwide. for foot leg amputations. The reason for this is diabetes is very damaging to both the blood vessels and the nerves. And if the blood vessels and the nerves to the foot are damaged,
not only does the person fail to feel
when the nerves are damaged, that they are stepping on things, that they're bumping themselves, that they're burning themselves, that they're causing damage, that their shoes are too tight. The problem with a blood vessel, if there's not sufficient blood supply to the foot, you get a major problem, and you will get gangrene, ulceration, and it will end up with an amputation. And this is what a typical blood vessel looks like, especially in somebody with type 2 diabetes. And very often at this stage, they don't even know that they have a problem. The neuropathy, that is the damage to the nerves, is also a double whammy because glucose flows into the nerve. Once again, the body tries to convert it into sorbitol, and that sorbitol damages the nerve. But at the same time, if the blood supply to that nerve is insufficient, that nerve is going to die. So with an insufficient blood supply and an accumulation of sorbitol and other nasty products, you get nerve damage. Diabetes is responsible for so many complications. And today we're going to talk mostly about the eye, but just remember that there are quite a few others that I will be mentioning as well. Now, this was brought to the media attention many years ago, like 30 years ago. They already started saying that there is a world problem, that there's a health crisis. Are you at risk? And it was both in the
popular press and various magazines around the world.
The public things like Time Magazine, Newsweek, etc., and also in the professional journals. And then if we look at a very interesting statement that was made at the World Economic Forum last year, they said last year, that's a year ago, that diabetes is increasing across the globe. And in fact, it killed 4.2 million people in 2019. And they made this amazing statement that it is a silent epidemic that is 3 times as deadly as COVID. I took the slide directly from their presentation. They also stated that middle and low income countries are seeing the biggest increases, with 460 million people already living with diabetes. And they expect that by 2045, this will almost have doubled. They also recommended that people do something urgent about changing their diet, start exercising, quit smoking.
We need to change our emphasis from exactly what the word says to health care rather than to sick care. In other words, don't wait until things go wrong. Act immediately. Act now to look after yourself, care for yourself, be alert for and prevent the disease itself and its complications from ever arising.
So if we look at this global epidemic, when I started in diabetes in about 1984, 85, somewhere around there, I started professionally, we were concerned that we had 25 million people worldwide with diabetes. And our concern was that by the turn of the century, we could be facing as many as 100 million. And to our horror, by the time the turn of the century came, we were already on 300 million people. And today, as I said, the stats for last year are 2,000. And you can see that this growth is exponential. And as we sit here, it's going up and up and up and up. In other words, we have a health catastrophe that is affecting every single one of us. And this is one of the major problems. This is one of the major reasons. If we look at the prevalence of obesity amongst the United States, and we're looking at the United States because they keep such really, really good stats. It's not that we're picking on them, we just know that their stats are pretty accurate. We know that from 1991 to 2001, that was just 10 years, the average in the country was far less than 10% of people who were overweight or obese. By 2001, this had doubled, and in some states had trebled to between 20 and 25% of the population. A few years later, more and more states were reporting more than 25%, and we know that this grew year by year by year. And today, we have almost half the United States with a prevalence of obesity of over 35%, and in some states, well over 35%. Now, what about children? Sadly, children are equally obese, equally overfed with the wrong foods at the wrong times. And this is laying the foundation for disasters. I read a paper just this morning that was done on 7-year-olds, and they found that out of, I think, 2,000 7-year-olds that they looked at, 80% of them had cardiovascular damage already starting, 7 years old. So, just to remind you once again what we're talking about, Michelangelo's David went on a visit to the United States. He spent 3 wonderful weeks there, and when he returned to Florence, he looked like that. So, this is what we need to address and to avoid. But now, how about South Africa? What about our stats? Can we be complacent? No. Just 4 years ago, the reported prevalence of overweight and obese people in South Africa was estimated at around 65%. But 2 years later, it had increased to 85%, according to the Biomedical Central Journal. So, if we look then at diabetes, you'll see it follows exactly the same trends, the identical trends to trends set by obesity, because they are two sides of the same coin. And we know that currently in South Africa, 12.8% on average of our population has diabetes. And this is why it is your genetic predisposition to obesity. In other words, have a look at what you look like in the mirror. Are you an apple or a pear? And the most important thing to do here is to measure whether you are an apple or a pear. Don't take it for granted. You can do it just with a piece of string or a ribbon, and you put that around your waist, wiggle backwards and forwards a little bit and see where it settles. That is your waist measurement. And your hip measurement is done exactly where your leg bends forward. You take the measurement there, not, for example, at the top of her bikini line here. And for those of you who know anatomy, we measure it over the greater trochanter of the femur. In other words, where the leg joins the hip. And if your waist is wider than your hips, you have a problem. And whether you are thin or what we call fat, whatever, if your waist is bigger than your hips, you have a possible problem developing, and you need to do something about it now. And as I said, we're talking a lot about obesity when we're talking about diabetes, which is also known as diabesity, but in some circles. And the reason for this is obesity goes hand in hand with what we call insulin resistance syndrome. And this is the stage of diabetes that causes a lot of damage before you know that things are going wrong. It's also called the metabolic syndrome, Raven syndrome. It's known as a whole lot of things. And insulin resistance basically destroys the entire body. And once again, just to remind you, it is a lethal problem, and it can be controlled, looked after by judicious eating and proper exercising. Now, the pathogenesis, what goes wrong here is when we eat the wrong things, the sugar goes up a little bit, the insulin that is put out by the pancreas is often faulty because the pancreas can't keep up with that demand. And at the same time, in the muscles, you don't get proper utilization of the insulin. You get what they call downgrading of the receptors. In other words, insulin is not going to let glucose into those cells, and you get a problem with the liver trying to control this whole thing. So as the person eats a lot, at the top there, the constant glucose in the blood, and this is especially if you eat a lot of simple carbohydrates, takeaway foods. That puts a huge demand on the pancreas, as we said. It tries to keep up. It puts out faulty insulin, but that can't go into the cells. Because the cells aren't getting glucose, the message going to the brain the whole time is, feed me. So then you eat more. And this whole vicious cycle goes on and on and on, and starts, in fact, to destroy you. I want to point out that once again, you don't know that things are going wrong until things go wrong. You only know that things have gone wrong in this whole big scenario here when you've ended up with a major problem. Because one of the most important things is to have a patent, open, nice blood vessel to take your blood with nutrients, glucose, everything, to every single cell in the body. And at the same time, to pick up all the waste products and take them away, because they're going to damage the cells if they're left there. Unfortunately, this is what the glucose, the insulin, everything does to the blood vessel in a person who has insulin resistance. And we know they have insulin resistance if they have that central obesity. And this blood vessel cannot take the amount of blood that that one can. And eventually it is going to clog up, it will block, and the person ends up with a heart attack, with a stroke, with kidney failure, with losing a limb, with problem in the eye, insufficient blood supply to the eye, and you start getting destruction of the retina and possible blindness. In other words, we are looking at a ticking time bomb with every person who has a bigger tummy than their waist. We are looking at a time bomb that needs to be addressed immediately. So now let's look at the full characteristics of this person. Let's see who we're looking at. We've said it's the person with a bit of a bump. That bit of a bump is a warning sign. And even if the person is quite thin, like the fellow in this picture, he is not fat, but he certainly has a tummy. He needs to pay heed. He needs to do something today. They also have a problem with their cholesterol. Dyslipidemia is just another way of saying a problem with cholesterol. So that needs to be checked regularly, because it will end up clogging those blood vessels, clogging the arteries to the essential organs in the body. They also have, not surprising, hypertension, because trying to pump the blood through to the whole body and to carry insulin and glucose and everything to where it's needed, the heart needs to work really, really hard. And with hypertension, we know it has its own entire set of complications. So if you have a cholesterol problem, hypertension, a bit of a bump, start getting treatment now. Ironically, their blood has a tendency to clot for absolutely no reason. It'll clot tomorrow. And then one of the cardinal signs that you can look for next time you go to a mirror is lift your arm. And if in your armpit or sometimes in the neck, you have this dark discoloration of the skin, that is a characteristic of this problem. That is characteristic of insulin resistance syndrome. These people also have sleep apnea. And if you sleep next to somebody, this is what it sounds like. You hear as they suddenly wake up and they're gasping for breath, they're gasping for air. And in fact, they wake themselves up as well with the sleep apnea. That is also a huge warning sign of this problem. And they have a salt intolerance. And funny enough, they love salt on everything. But now notice that although we're talking about diabetes, I have not said a word about blood glucose yet. Why not? Because the blood sugar going up is the last thing that happens. You can have this problem for years and years, causing damage and disaster throughout your body. And you test your blood sugar and it looks fine. The fact that your blood sugar is fine just means that your body is kind of managing to cope. But how well? And unless we start intervening now, long before that blood sugar goes up, long before, you could end up with motor and sensory loss in your limbs, amputations, heart attacks, retinopathy, cataracts, strokes, all the things that we've spoken about. And as I said, just to remind you, this is a ticking time bomb. This is a major problem. So when should we intervene then? Exactly what I've just said. At the very first warning sign. The moment you get that little bit of a bump, the moment your tummy starts to get a little bit bigger than your waist, the moment your cholesterol starts getting out of control, you start eating a bit more, drinking a little bit more than yesterday, etc. Any warning sign, you react to immediately. Now, in type 2 diabetes, there's some things that we can't do anything about. If you have a history of gestational diabetes in a pregnancy, that's a given. You can't do anything about race or your age or your family history, but you can do a lot about your physical inactivity because the insulin in your body cannot function if you are not exercising. You need to do a reasonable amount of exercise every day. And we'll discuss that a little bit more just now. You don't have to go and
Run a marathon or
join a gym and do 3 hours. We'll tell you what to do. Your increase in your body fat, especially around the middle, high blood pressure and high cholesterol are all things that you can control. Blood pressure and cholesterol with the help of your doctor, and the others are up to you. Physical inactivity you can correct with exercise, and correct eating is very, very important. So be alert. Don't wait for your blood sugar to go up. That's too late. And your treatment needs to be now. And the first thing we need to do is to introduce lots of color into our diets and to exercise. And making the choice between the bad food choices or inappropriate food choices and good food choices are your decision every single time you eat. Now, I'm not saying that you can never have a South African braai with lots of brown and white foods with, boerewors and pap and steak and chips and things like that. But it should be a treat. It shouldn't be every day. Most days, you should be having a diet rich in every color of the rainbow. And we look at that again. exercise also doesn't have to be absolutely frantic. And what we do recommend, if you're not doing anything else and you don't want to walk around because you're afraid of bumping into people and lockdown and the whole story, you can do things at home. And one of the things that we do look at is intensity training, which is actually very, very easy for you to do. You can do one of two things. This only takes 40 seconds, 40 seconds, 40 seconds, 40 seconds, 3 times a day. That's all. And I'm sure you can spare 4 minutes a day to look after your health. So what you do is you can sit on your chair or a couch and you cycle in the air with your arms like that. Just cycle forwards for 40 seconds and then backwards for 40 seconds and then forwards as fast as you can for 40 seconds and backwards as fast as you can for 40 seconds. We can make that even shorter if you want to do that same thing with your legs. Cycle with your legs as big as you can, make big cycles in the air with your legs, but then you can halve the time. It can be 20 seconds, 20 seconds, 20 seconds forward, 20 seconds back, 20 seconds forward fast, 20 seconds back fast. So if you do that 3 times a day, you're taking a huge step towards protecting yourself from the dangers of diabetes. So the doctor said he needed more activity. I hide his TV remote 3 times a week. No, that's not enough. He needs to sit on that couch and do the exercise that I've just told you if he's reluctant to go outside for a nice walk. Obviously, doing a walk and that is the best. The ABC of control, you need to look after your sugar, you need to look after your blood pressure, and of course, you need to look after your cholesterol. Blood glucose, we need regular monitoring. And I'm appalled at how often I say to people, how often do you test? And they say, oh, I test regularly, at least once a month or once a week, or that means nothing. We need regular monitoring at different times every day. Fasting, when you wake up in the morning, before and after meals, and at bedtime. So that's 7 or 8 tests a day. But I'm not saying you have to do them all on one day. Do 1 test a day at a different time each day to give us an overview of how your body is really coping with what is going on in your body. We also know that glucose variability, swinging glucose, is very, very, very damaging to the body. It's even more damaging than having a slightly raised blood sugar that is fairly constant. We also need to control your cholesterol, your lipid levels, make sure they're okay. And remember, for all of this, we strive for 5 to stay alive. And blood pressure needs to be controlled at all times. Now, some interesting news of what is on the horizon. Apple Watch bring out new developments every time they launch a new watch. And it is rumored, but Apple always send out rumors before they do things. It is rumored that the Apple Watch 7, which is due for release later this year, has an inbuilt glucose meter that it will be able to measure across the skin. Now, this is great because not only will people be able to monitor their glucose 24 hours a day, it will also alert people who are unaware that they are developing a problem, that sometimes after a meal, their body is not coping as well as they thought. So the thought is that we could pick up a lot of people with developing diabetes in this way as well. Obviously, this is very, very first world because the Apple Watch, as you know, is quite pricey. Now, there are multiple treatments for type 2 diabetes, and I'm not going to go into all of them. I'm just going to mention that your doctor will probably start you on the biguanides, that's metformin or glucophage. They then, if needed, go on to one of the other options. There's sulfonylureas, thiazolidine-diones, alpha-glucosidase inhibitors, the meglitinides, and incretin mimetics. And sometimes they'll even give you the anti-obesity drugs. But the reason I'm talking about the medication is people often say, but my neighbor is taking that, but my doctor's given me this. Isn't that one better? No, everybody is different. Every single person reacts differently to different medications. So you have to just trust your doctor and take your medications the way they are prescribed for you. Don't share with your neighbor. Don't try one of their pills. You could cause major problems, so don't do it. And then if needed, you could go on to insulin for a day, a week, forever. It just depends how long that you might need it for. One of the treatments that we have, if things go wrong in the eye for people with diabetes, is the anti-VEGF injections. As I mentioned to you earlier, if your doctor looks into the eye, they will be able to see that if your eye is not being fed adequately, the retina of your eye, with sufficient nutrients, sufficient oxygen, and everything that is needed, your body tries to compensate by making lots of extra little blood vessels all over the place. And it does this in the heart, it does it everywhere that might be needed in the body. And it might be a good idea elsewhere, but in the eye, it's a terrible idea because those blood vessels, those new blood vessels, are very fragile. They are as bad as our South African roads at the moment. They're full of potholes, they rupture, they are a disaster. So to get rid of them, your doctor could give you an anti-VEGF injection. There are 3 types available on the market at the moment, and there's a 4th being launched any day now. And one of these is off-label. The important message here is that if you start on one anti-VEGF injection and it hasn't had a decent result within 2 or 3 months, your doctor will probably change you to one of the other options, because luckily, with so many options, we do have choices, and it becomes easier to find something that suits you. And just remember that with the off-label one, there is a problem and should not be used with people who have severe cardiovascular problems, who is everyone with diabetes, I guess, anyway. So let's have a quick look then at the future, because there is so much going on into research to address the problems that diabetes causes in the eye. And there are some wonderful trials that are looking so promising and so exciting. The first one is subretinal gene therapy. And this is being looked at for both AMD and diabetic retinopathy. And what subretinal gene therapy does is it increases the action of the anti-VEGF injection that you take. You have a subretinal injection of this product. It's called AVA 101 at the moment. It will probably get a different name when it comes on the market. Then in the following 6 weeks, you have 2 separate treatments, also of AVA 101, and then 1 injection of anti-VEGF. And then anti-VEGF only again if needed. And in the trials, this is looking so good that even a year to 18 months later, people have not required a second injection. So this could be launched within the next few years, depending how the trials actually end up. The way this works is it is a DNA strand packaged inside an adeno or adeno-associated virus, depending which side of the Atlantic you're from. And they give you just 100 microliters. That's a tiny dose of AVA 101 injected under the retina. And they found that with this treatment, patients actually gained vision after 12 months. They gained up to 9 to 12 letters on the eye chart. So that's pretty significant. The Runx inhibitors, now here's another one. This is another one that's also very, very exciting. And as I said, there are hundreds of them out there. I've just chosen 2 at random because maybe I like the names. The Runx one made me think of a motor car. It is currently in very, very early research. And it is also to address neovascularization and response to anti-VEGF. Now, Runx is a problem because in the body, it actually promotes the blood vessels to form. So if we give the Runx1 inhibitor in an eye drop 3 times a day, we can stop those blood vessels from forming, those fragile, delicate blood vessels that could rupture in the retina and eventually cause blindness. So in other words, you give these drops 3 times a day, they reach the retina and help to stop the little blood vessels forming. And it is thought that in the beginning, it could be used in conjunction with anti-VEGF, and then we just need to watch that retina very, very carefully as it goes on. I'm going to just say a word or two, because people often say, with diabetic retinopathy, how often should I see the ophthalmologist? How often should I follow up, etc.? Right. If you have no signs and symptoms, you need an annual checkup. If you have diabetes, your eyes must be checked every single year, because your ophthalmologist will pick up problems in your eye years before you become aware that anything is going wrong there. And you can actually have pretty advanced damage without even knowing that things are going wrong in the eye. If you have mild, non-proliferative diabetic retinopathy, they call it, you need to also go at least once a year, more often if your doctor is worried. Moderate, every 6 months. And your ophthalmologist will guide you about this. If it is severe, you need to go 3, maybe 4 monthly, probably 3 monthly. And if you have diabetic macular edema, where you have swelling of the retina, you need to go every 2 to 3 months. And with proliferative diabetic retinopathy, also every 2 to 3 months. But as I said, your doctor will monitor your eyes and will be able to tell you exactly when you should return. I could have done this entire talk just on this slide. In other words, watch your lifestyle. Look after yourself. Eat judiciously. Don't eat too much junk food. Don't eat too many cakes and sweets. Eat the correct things. We all know what the correct things are, actually. Lots of colored foods every day. And exercise. Go for regular checkups and screening. You need to have your eyes screened if you're over the age of 40, at least every 1 to 2 years anyway. And then you need to work with your full medical team. And I don't even have everybody listed here. The team is you working with your diabetologist, your ophthalmologist, your optometrist, your diabetes educator, the full nursing team, your occupational therapist, dietitian, psychologist, social worker, a mobility instructor, etc., etc., etc. This is a team approach that we all need to work together to beat this horrific pandemic that, as we said earlier, is 3 times more prevalent than COVID. Prevention is much better than eventually trying to cure what has gone wrong. Thank you.
Karen, thank you. That was absolutely amazing. I think that there are not, at the moment, no questions that have come up, but I have a question.
Yeah.
I have retinitis. I have retinitis pigmentosa. So therefore, I don't have to worry about diabetic retinopathy. Is that true?
No, they are completely different, completely separate. They affect different parts, in fact, of the retina. They affect different parts of the body. And with something like you already have, it does not rule out that in addition to that, you could have a bit of bad luck and develop diabetes as well. But then I know you won't, because you exercise judiciously. You, in fact, teach yoga. You eat correctly. So, yeah. So I would say that you're pretty low risk. The only risk I think you have is because you and I are the same age, and maybe at our age our bodies aren't functioning as well as they should.
Okay, so we know that a BOP is something that a lot of South Africans have, and people ignore it. So would you say that is actually the first warning sign?
Yeah, but then it's not surprising that we have so many people in this country who have heart attacks, they have myocardial infarctions, they have strokes. You hear about it all the time, and nobody looks back to see what went wrong first. And I just want to mention, while we're talking about this, I actually read this morning another paper that 15% of people being admitted to hospitals worldwide are being diagnosed with diabetes. And they're not sure whether this is directly that the COVID is destroying the beta cells, the islets, or if the fact that they have COVID is unmasking what is already going wrong. So that is a platform for major research that's going to be taking place now. But I suspect that it's both, because the numbers are quite high.
Probably. And we also know that in many cases, well, in some cases, eye damage, retinal damage particularly, has been reported as in people who have COVID, but that are asymptomatic.
Yeah, absolutely.
Oh, so we have some people who have commented, like Alta and Lorraine, to say thank you very, very much for a very informative talk. And we also would like to remind people that CPD, pardon me, always when you're on screen, you've got a cough, you've got a frog.
Yeah.
CPD points have been applied for. And if you want to inquire about CPD points, you can email Gail at retinasa.org.za or Claudette at retinasa.org.za. And I think that if anybody else now has any questions, any further questions, could you please post them now? If you're a bit shy and you don't want to put your post on, we can always answer your questions via email. And somebody has anonymously said, excellent presentation. Thank you very much for the information. And also to remind you that this talk is being recorded, and all this talk and all our other webinars can be accessed via our website, which is retinasa.org.za. Can you see my screen, Karen?
Yes.
Okay. And also, if you go to our website and look for Learn, and look at the pull-down menu and type webinars, you will get recordings of all our webinars, including this one, but give Karen a bit of time because she now has the onerous task of actually editing her own webinar. And we'd like to appeal to you to actually help us support research at no cost to you. You can nominate us as your beneficiary at myschool.co.za. So all you do is you can go online and nominate us, Retina South Africa. And if you're not sure, you can always email our office, head office at retinasa.org.za, or call us on share call 0860 595959. And if you have any specific questions for Karen, we will send them through to her.
I think a question has just arrived. And then I just want to point out with the My School that you can have 3 beneficiaries.
Hi, Alta.
Could I just also remind everybody that we do have a survey, which we request that they please fill in so that we can evaluate tonight's presentation. Not that it needs evaluation, because it was brilliant.
Thank you very much. Okay, we have a question from Elsie. It says, Karen, what about glaucoma? And my question to Elsie is, do you have another hour now, or would you like that later?
Yes. People with diabetes are at higher risk for glaucoma as well, so that needs to be checked regularly.
And I think we can just very quickly say that glaucoma is very much like diabetic retinopathy. You don't know about it until it's too late. And the only way to prevent yourself getting it is actually by regular eye checks. And without further ado,
no, there's one more. My wife has black spots under the arms. She needs to get that checked out.
Oh, okay. You're seeing things.
But as I said, you don't know that you don't have diabetes because your blood sugar does not go up until it's the last thing to go up. So let her be checked for the tummy and the other things like blood pressure, cholesterol, all of those things. The blood sugar is the last thing to look at regarding diabetes, because the blood sugar only goes up sometimes after the patient has had this problem for 20, 30 years, and they think they don't have diabetes, but they have all that damage happening. So it's just worth checking. You can pop into the pharmacy and they can check cholesterol and blood pressure, or the doctor can do it. And then, of course, just make sure that you all eat judiciously and well and do a bit of exercise.
And I think it's also important for people to realize that even an optometrist who's got a fundus camera can actually take a picture of your retina. And those microaneurysms will show up long before you have vision loss. And it's very important to have that check done. So if you are already going to your optometrist for a pressure test, which of course you should do to avoid increased pressure, which leads to glaucoma, ask him to take a fundus photograph of your retina. And if he can't, he should refer you to an optometrist or your ophthalmologist, who can certainly do that for you. And I think that is all the questions that we have. But do remember that if you have further questions, you can always email any one of us, and we will make sure that Karen gets to answer your question. So Karen, on behalf of all the people that logged in, and there were over 50 tonight, we would like to thank you most sincerely, again, for giving us of your knowledge. You know, they say that knowledge not shared is lost, and you're certainly not losing your knowledge because you share it so generously. And we know it's a lifetime of work that you've accumulated all this knowledge, and you share it very generously with all of us. So thank you very much, everyone, and good night, and we'll see you on our next webinar.
Perfect.
Thank you.
I look forward to that.
Fantastic.